Welcome back to the Nurses Study Partner. This is Tetanus, Part 1, the cause, the toxin, the signs, and how we recognize it in 10 in-depth scenarios. We will cover Clostridium tetani and how it enters through wounds, how tetanospasmin blocks inhibitory signals to cause spasms, the classic signs of trismus, rhizus sardonicus, and opisthotonus, the key point that the patient stays conscious, what incubation tells us, neonatal tetanus, and why diagnosis is clinical. Read each case, weigh all 4 options, pause to choose, then check your reasoning. Let's begin. Question 1. A student nurse asks which organism causes tetanus, where it is found, and why a deep wound from a rusty nail is so dangerous. Which description is correct? Option A. A virus spread person to person by coughing and sneezing. Option B. Clostridium tetani, an anaerobic spore former in soil and feces. Option C. A fungus that only grows on clean, well-oxygenated skin. Option D. A harmless gut bacterium that never causes any disease. Pause here and choose your answer. The answer is B. Clostridium tetani, an anaerobic spore former in soil and feces. Tetanus is caused by Clostridium tetani, a gram-positive obligate anaerobic spore-forming rod with a drumstick terminal spore. Its spores survive in soil, dust, and animal and human feces, and on objects like rusty nails. A deep puncture wound provides the low oxygen environment the spores need to germinate. It is not a virus, a fungus, or harmless. Question 2. A farmer sustains a deep puncture wound contaminated with soil and manure. Why is this wound high risk for tetanus? Option A. Only clean, shallow scratches ever cause tetanus. Option B. Tetanus is caught by breathing contaminated dust in air. Option C. Well-oxygenated wounds are the most dangerous of all. Option D. Deep, dirty, low-oxygen wounds let spores germinate. Pause here and choose your answer. The answer is D. Deep, dirty, low-oxygen wounds let spores germinate. Tetanus is a wound infection. Deep, dirty, devitalized wounds, punctures, and those with soil, manure, foreign bodies, or dead tissue create the anaerobic low-oxygen environment that lets spores germinate and produce toxin. Burns, the umbilical stump in neonates, bites, and injecting drug use are also routes. It is not caught by breathing, and clean oxygenated wounds are lower risk. Question 3. A student asks how a toxin from a wound in the foot ends up causing whole body muscle spasms and what the toxin does in the nervous system. Which best explains the mechanism? Option A. It thins the blood and stops the heart from beating. Option B. It boosts calming signals so muscles fully relax. Option C. It blocks inhibitory GABA and glycine, causing unopposed spasms. Option D. It only affects the skin locally, never the nerves. Pause here and choose your answer. The answer is C. It blocks inhibitory GABA and glycine, causing unopposed spasms. The toxin tetanospasmin travels retrograde up nerves to the central nervous system and spinal cord, where it blocks the release of the inhibitory neurotransmitters GABA and glycine. Losing this inhibition leaves motor neurons unopposed and overactive, producing sustained muscle contraction, rigidity, and spasms, a spastic paralysis. It does not thin blood, relax muscles, or stay purely local. Question 4. A man who stepped on a nail a week ago now cannot open his mouth properly, with tight, painful jaw muscles making eating and speaking difficult. Which classic early sign of tetanus is this? Option A, trismus or lockjaw from masseter muscle spasm. Option B, a simple dental cavity needing only a filling. Option C, an allergic swelling of the lips and tongue only. Option D, ordinary jaw ache from chewing tough food lately. Pause here and choose your answer. The answer is A, trismus or lockjaw from masseter muscle spasm. Trismus, spasm and rigidity of the jaw muscles, is the classic and often first sign of tetanus, making it hard to open the mouth. Given the recent puncture wound, this strongly suggests tetanus and warrants urgent action. It is not a simple cavity, an allergy, or ordinary jaw ache. Question 5. A patient with tetanus develops a fixed grimacing facial expression and later episodes where the back arches rigidly backward during spasms. Which two classic signs are being described? Option A, nystagmus and ptosis of the eyelids from nerve palsy. Option B, rhesus sardonicus, a grimace, and opisthotonus, an arched back. Option C, a butterfly facial rash and swollen, painful finger joints. Option D, facial droop and one-sided arm weakness from a clot. Pause here and choose your answer. The answer is B, rhesus sardonicus and opisthotonus. Rhesus sardonicus is the fixed sardonic grin from sustained facial muscle spasm. Opisthotonus is the rigid backward arching of the spine during generalized spasms. Both are hallmark signs of tetanus, along with neck stiffness, difficulty swallowing, and board-like abdominal rigidity. These are not eye movement signs, a lupus rash, or a stroke pattern. Question 6. A nurse notes that her patient with tetanus is fully awake and aware during the painful muscle spasms, which are set off by noise, bright light, and being touched. Which statement is correct? Option A. The patient is always deeply unconscious during spasms. Option B. Spasms happen randomly and are completely painless. Option C. The patient stays conscious. Stimuli trigger painful spasms. Option D. Bright light and noise make the spasms stop at once. Pause here and choose your answer. The answer is C. The patient stays conscious and stimuli trigger painful spasms. A key feature of tetanus is that the patient remains fully conscious and alert, but the toxin affects motor control, not consciousness, and the spasms are intensely painful. They are often triggered by stimuli such as noise, light, touch, and movement, which is why care includes a quiet, calm, low stimulation environment. So patients are not unconscious, the spasms are not painless, and stimuli provoke rather than stop them. Question 7. Two patients develop tetanus. One shows symptoms just 3 days after injury, the other only after about 3 weeks. What does this mean for prognosis? Option A. A shorter incubation generally means a worse prognosis. Option B. A shorter incubation always means a much milder illness. Option C. The incubation period has no bearing on the outcome. Option D. Tetanus symptoms always begin within a few minutes. Pause here and choose your answer. The answer is A. A shorter incubation generally means a worse prognosis. The tetanus incubation period is typically about 3 to 21 days, often 7 to 10. A shorter incubation and a short interval from the first symptom to the first spasm generally indicates more toxin and a worse prognosis, while a longer incubation tends to be milder. So incubation does affect outcome. A short incubation is not milder, and symptoms do not start within minutes. Question 8. A 7-day-old baby delivered at home where the cord was cut with an unsterile blade now feeds poorly, cannot suck, and has stiffness with episodes of whole body spasm. Which condition should the nurse strongly suspect? Option A, normal newborn behavior needing only reassurance. Option B, simple colic that will settle with winding and time. Option C, ordinary hunger. The baby just needs more frequent feeds. Option D, neonatal tetanus from unclean umbilical cord care. Pause here and choose your answer. The answer is D, neonatal tetanus from unclean umbilical cord care. Poor feeding and inability to suck, stiffness and spasms appearing around days 3 to 14 of life, especially after unclean cord cutting or care, are classic neonatal tetanus. Spores enter via the umbilical stump. It carries high mortality and is preventable by maternal tetanus immunization and clean delivery and cord care. This is not normal behavior, colic, or hunger. Question 9. A patient presents with a wound, trismus, and muscle spasms. The junior nurse asks which blood test will confirm tetanus before treatment can begin. Which statement about diagnosis is correct? Option A. A single blood test rapidly confirms tetanus every time. Option B. Diagnosis must wait weeks for a culture to grow. Option C. Diagnosis is clinical. Treat on suspicion. Don't delay. Option D. Only a brain scan can ever diagnose the condition. Pause here and choose your answer. The answer is C. Diagnosis is clinical, so treat on suspicion and don't delay. Tetanus is diagnosed clinically from the history of a wound and immunization status, plus the typical features of trismus, spasms, and rigidity. Because there is no reliable rapid blood test and cultures are often negative, treatment must not be delayed waiting for tests. The spatula test, touching the posterior pharynx, provokes a reflex jaw clench rather than a gag, can support the diagnosis. It is not confirmed by one blood test, a slow culture, or a brain scan. Question 10. A patient has generalized muscle rigidity and spasms, and the team weighs tetanus against other causes. Which feature most helps point specifically to tetanus? Option A, a tetanus-prone wound with trismus and a preserved conscious level. Option B, complete loss of consciousness with flaccid, floppy limbs. Option C, isolated fever and a cough with no muscle involvement. Option D, painless weakness that improves with gentle exercise. Pause here and choose your answer. The answer is A, a tetanus-prone wound with trismus and a preserved conscious level. The combination of a tetanus-prone wound, trismus, muscle rigidity, and painful spasms with a fully preserved conscious level points strongly to tetanus. Differentials include dystonic drug reactions, strychnine poisoning, low calcium, meningitis and dental abscess, but the wound history plus lockjaw with alert consciousness is characteristic. Flaccid paralysis, an isolated cough, or painless weakness are not tetanus. Let's recap tetanus part 1. Tetanus is caused by Clostridium tetani, an anaerobic spore-forming organism from soil and feces. It enters through deep, dirty, low-oxygen wounds where spores germinate. Its toxin, tetanospasmin, blocks the inhibitory neurotransmitters GABA and glycine, leaving muscles in unopposed spasm. Trismus or lockjaw is the classic first sign, followed by rhizus sardonicus and opisthotonus. Crucially, the patient stays conscious and stimuli trigger painful spasms. A shorter incubation means a worse prognosis. Neonatal tetanus follows unclean cord care with poor feeding and spasms. And diagnosis is clinical. Treat on suspicion. Don't wait for a test. Keep going and remember, we don't pass alone, we pass together.